it's Dr. Tobias Carling here from the Carling Adrenal Center, and a lot of you know that today is the first ever Conn's Syndrome Awareness Day. So April 14th from now on is known as the Conn's Syndrome Awareness Day, and today we're going to have a discussion about Conn's syndrome, and this is part of a bigger discussion about during the month of April, which is the Adrenal Awareness Month, where all adrenal diseases are highlighted. But today we're going to especially focus on the Conn's syndrome, or another name for it is primary hyperaldosteronism. That's when your adrenal glands have one or more tumors that overproduce aldosterone, causing too high blood pressure and low potassium and so forth. So 1 out of 10 of all patients with high blood pressure, so we're talking about millions of patients in the United States, around the world, have underlying Conn syndrome. So 1 in 10, so 10% of all patients with high blood pressure have underlying primary hyperaldosteronism. Unfortunately, it remains highly underdiagnosed and undertreated. So it's not a rare disease, it's just a rare diagnosis. So again, Conn syndrome is when you have too much aldosterone produced by the adrenal glands. And aldosterone is a very toxic hormone because it affects every cell of your body. But specifically, it can cause high blood pressure, low potassium, fatigue, muscle cramping, frequent urination, anxiety, sort of neurocognitive symptoms, meaning how we feel and how our brain functions, so anxiety, depressive symptoms, even panic attack symptoms. Sometimes you have swelling in the legs and so forth. And we're also very excited about this partnership you may have seen highlighted on our social media together with Any Lab Tests Now. So it's a company that's located all around the United States with multiple locations, and together with them we have created something called an Adrenal Insights Panel, and that's simply lab tests that specifically test for your adrenal function and whether you have an adrenal tumor. So if you go to a doctor and do regular tests, meaning your blood count and your chemistries, those wouldn't show an adrenal tumor. So you need to specifically look for aldosterone and renin and some other lab tests. And that's what this adrenal panel provides with the Any Lab Tests Now partnership. So we're very excited to announce this partnership. So again, Any Lab Tests Now is a national direct access lab with 230 locations. And they do, through our partnership, make adrenal testing more accessible, affordable, and convenient. So you can literally go to one of those locations and have adrenal testing performed. So let's talk about Conn's syndrome. So what causes Conn's syndrome, and is it genetic? That's a great question. So what causes Conn's syndrome is classically you have one of two scenarios. You either have an adenoma, a benign tumor that's overproducing aldosterone, or you have overproduction of aldosterone diffusely from both glands. That used to be called hyperplasia. And sometimes we use that term hyperplasia, but it's a little bit more complicated than that. But bottom line, you either have a tumor, multiple tumors, or both adrenal glands are overproducing aldosterone. And aldosterone goes then throughout your body, through the bloodstream, and affects a number of different functions. But it raises the blood pressure, makes you pee out the potassium, so the potassium in your bloodstream is low, and that's what's causing all the symptoms. In most cases, when we talk about genetic diseases, you can have genetic diseases that it's a single gene that you pass on, and it's often what we call autosomal dominant, so 50% of the offspring, meaning your kids, have a risk of having it. That type of primary hyperaldosteronism does exist, but it's very, very rare. and that's called familial hyperaldosteronism. That's rare that you have that one single gene, and some of the work we did at Yale University identified that gene that causes it. So again, that's very rare, but can occur. Usually happens in childhood, meaning you have very, very severe hyperaldosteronism as a kid. But then you can have what's called polygenic diseases, meaning that you have multiple genes that creates accumulation of cases within a family. And that happens more commonly in Conn syndrome, meaning it's not a single gene that's causing it, but some families are more prone to it. But then in the vast majority of cases when you have a single adenoma, an aldosterone producing adenoma, it's genetic in the sense that you acquire a mutation in a gene, meaning it's not something you inherited from your parents, but what happens in the adrenal gland is you have mutation in a gene that controls the potassium and calcium flow of the granulosa cells, and that's what's causing too much aldosterone production and tumor growth. So again, what causes Conn syndrome, so it has to do with those mutations. Most mutations are acquired, meaning it happens in the tumor, similar as you have acquired mutation in the breast cancer or colon cancer, for instance, but rarely it can run in families. Does Conn syndrome have any markers, any indicators to help earlier detection? Is it more common in women than men? Older versus younger, a specific race? Those are all great questions. Well, the earliest markers typically is high blood pressure and low potassium. So most patients, almost all patients, have high blood pressure, and it's an early indication that you have Conn syndrome is that the lower number, what we call the diastolic blood pressure, is the one that's going up first. So normal blood pressure is, say, 120 over 80. But if that lower pressure is a little bit higher, say 90, 120 over 90, or 130 over 90, or 95, or even 100, that's often the first indication. And then if your potassium is less than 4, those are early markers that you have Conn syndrome. And that helps with early detection. But by far the most important thing for early detection is you gotta have your aldosterone and renin levels measured. I'll say that again. The best way to figure out if you have this early, measure your aldosterone, measure your renin. If the aldosterone and the renin ratio is 20 or higher, that means you likely have Conn syndrome. So it's a simple blood test. Again, measure your aldosterone and renin. Measuring the aldosterone without the renin is useless. Measuring the renin without the aldosterone is useless. So you have to measure both of them at the same time. Is it more common in women than men? Yes, it's slightly more common in women than in men, but it occurs in both groups. It happens in all age groups, but it typically happens or is diagnosed sort of middle age group. So anywhere from your 30s to 60s, but certainly we see people in their teens and late teens and early 20s have it, people in their 70s and 80s, so it can happen in all age group. It affects all ethnicities. What is interesting that some of those genetic mutations that I spoke about, that they are a little bit different, that they are more frequent in some ethnicities than others. For instance, in Asians, having a specific mutation in a gene called KCNJ5, which is the gene we identified when I was the chief at Yale University, that is the most common gene mutation that happens in tumors. That is more common in the Asians. That's been shown in studies in Japan, in South Korea, and China, and so forth. I've been on 3+ blood pressure medications for years. Should I be tested for Conn syndrome? Yes, absolutely. So, number one, anybody with high blood pressure should be tested for Conn syndrome. I'll say that again. Anybody who has high blood pressure should be tested for Conn syndrome. Why? Because 10% of patients have with high blood pressure have underlying Conn syndrome, and it's easy and affordable to check for Conn syndrome. So it's definitely worth it. But then there are some certain groups that definitely should be tested. So in my personal opinion, everybody with high blood pressure should be tested for Conn syndrome. The current recommendations, guidelines from the Endocrine Society, from the American Heart Association and so forth, is that for patients that have hypertension at a young age, less than 50, or on more than one blood pressure medication, that has a family history of hypertension, that has an adrenal incidentalloma, that has low potassium levels, and have what we call refractory hypertension, meaning difficulty to control blood pressure. All of those individuals should be screened for an aldosterone-producing tumor, meaning Conn syndrome. But again, in my heart of hearts, I think everybody should be screened, because why would you not want to know that you have underlying Conn syndrome, since we do know that you can actually have your hypertension fixed, with a 20-minute operation if you have Conn's syndrome. So again, absolutely, 3+ blood pressure medication, 100% should be tested for Conn syndrome. What are the long-term risks if Conn syndrome goes undiagnosed or untreated? Yeah, so this has to do with the toxic effects of too much aldosterone. So again, aldosterone is a necessary hormone. Like all hormones, it should be balanced. So if you have a good amount of aldosterone, that's good for your body. But when it's too high, it's very toxic for your body, because aldosterone specifically affects the inner lining of blood vessels. That's what we call endothelium. So the inner lining of blood vessels is very important, because that's what makes the blood flow go smoothly through all the vessels. So if you can imagine, if you have disruption to that endothelium, it causes a lot of cardiovascular risks. So the risks of too much aldosterone is cardiac. So the risk of atrial fibrillation, heart arrhythmias, heart attacks, left ventricular hypertrophy, that's when the heart grows too big, are all significantly elevated in patients with Conn syndrome. When it has to do with your brain, the brain is obviously very dependent on good blood flow, so increased risk of strokes and other cardiovascular issues. Then the kidneys, same thing with the kidneys, is if you have reduced blood flow to the kidneys, it leads to chronic kidney disease. So the kidneys are very susceptible both to the high blood pressure in of itself, but the direct effect of aldosterone. So all those things, especially your brain, your heart, and your kidneys. But again, the aldosterone affects every cell of your body, so there's a lot of other risks to the body, but those three are the major ones. Can Conn syndrome cause anxiety, panic attacks, or mood changes due to hormonal imbalance? Yes, absolutely. So again, this has to do with the fact that the aldosterone affects every cell of your body, and there's been a lot of quality of life studies that looked at this specifically, where people are analyzed. So patients with hyperaldosteronism or Conn syndrome are compared to a control group, what kind of symptoms they have when it comes to quality of life issues. So a lot of that has to do with depressive symptoms, anxiety symptoms, mood changes, fatigue, lack of energy, this panic attack symptoms. So all those are significantly elevated in patients with Conn syndrome, and quite remarkably, that comes back down to a normal baseline after patients have successful surgery. So it's clear that this is caused by hyperaldosteronism, and it's reversible once the tumor is removed. can Conn's syndrome increase the risk of stroke or heart attack even if blood pressure is controlled by medication? A great question, and unfortunately the answer is yes, absolutely. So, of course, if a patient has high blood pressure due to Conn syndrome, you should be on blood pressure medication because you want to bring that blood pressure down. But if you compare two groups, patients that have high blood pressure that is caused by Conn syndrome compared to a group that have high blood pressure that's what we call essential hypertension, meaning it's not caused by Conn syndrome. Patients with Conn syndrome have a lot higher rate of heart attacks, stroke, and atrial fibrillation than those that have just garden variety blood pressure. That's why it's so important that all patients with high blood pressure needs to be screened for Conn syndrome. Because we do know, but removing that aldosterone producing tumor, that brings that risk down significantly for patients. So of course it's better to treat with blood pressure medication than to do nothing, but comparing surgery versus just medical treatment, there's no question that surgery is significantly and many multitudes much better than just treating with one blood pressure medication after another. Why doesn't my doctor know about Conn syndrome? They've been prescribing me medication for my blood pressure for 5 years and testing my potassium with testing my potassium with supplementation. I think that should be replacing my potassium with supplementation. If it's such an easy diagnosis, why don't they know about it? So first of all, again, this is not a rare disease, but it's a rare diagnosis. So a lot of doctors, whether they're primary care doctors or nephrologists or even endocrinologists, may not see many patients or diagnose many patients with primary hyperaldosteronism. There's been such a rapid improvement in our understanding of this disease over just the last 2 to 5 to 10 years that a lot of the information doctors have may be what they learned in medical school several years ago. So they might not be up to date on how common this is. And if you're not looking for it, you're going to miss it. And in defense to primary care doctors, they might see 20 to 30 patients in a single day, and a lot of them have high blood pressure. So unless they're under a time constraint. So unless they're thinking about it, and that's what we're trying to with this Conn syndrome awareness, is just to get an awareness that this disease is very common. So for instance, we're definitely through this channel and through adrenal.com, and then I'm often an invited speaker to many conferences. So for instance, I'm giving presentations at the American Association of Clinical Endocrinologists, at the Endocrine Society, which is the biggest endocrinology meeting in the world, and at the International Aldosterone Society. So we're out there trying to educate doctors as much as we can, but again, often patients, patients could be their own advocates, and that's part of the reason we partnered with Any Lab Tests Now, because this puts makes the patient empowered to be able to have this relatively simple lab tests done. Again, what you want to see is an elevated aldosterone renin ratio, as well as see what your potassium is, and that's clinches the diagnosis. Yeah, what if my aldosterone and renin levels came back borderline? Should I test again? Yeah, this is a great question. So obviously in an ideal scenario, either the lab testing is conclusive that you have it, right? Meaning the aldosterone is high, the renin is low. easy peasy, the patient definitely has the disease. Or conversely, which is obviously helpful, your renin is completely normal, aldosterone is completely normal, so you don't have Conn syndrome. But sometimes, like in real life, there can be gray areas, right? And absolutely, if your testing was borderline, you should have it retested. One of the reasons sometimes that the testing can be borderline is because of effects by blood pressure medications. So sometimes blood pressure medications can err on showing that lab levels are borderline when they really are elevated, meaning that the blood pressure medication masks the hyperaldosteronism, and especially the medication eplerenone and spironolactone can falsely lower the aldosterone. But I'm a firm believer that you should have, certainly when you have borderline testing, have it repeated, absolutely. There's some confirmatory testing that sometimes can be used, such as the 24-hour urine aldosterone, which sometimes can be helpful. And you always want to have the aldosterone and renin levels tested at least twice. So you want to have it tested twice. So if you only had it once and it was borderline, absolutely you should get it retested. I have a high aldosterone and high aldosterone renin ratio, but my CT is negative. Does this rule out Conn's syndrome? No. So Conn syndrome or primary hyperaldosteronism is a biochemical diagnosis, meaning it's based on the labs together with the symptoms. So definitely, if you have it, that may mean that the tumor is too small to be picked up on CT scan. So this is where adrenal vein sampling comes in. So not all patients need adrenal vein sampling. So if you have an obvious tumor on the CT scan and the other gland looks completely normal, those patients can go straight to surgery. But if you have tumors on both adrenal glands, or as in this case, the CT scan doesn't show a tumor, that may mean that the tumor is too small to show up on a scan, and those patients often benefit from having adrenal vein sampling. Adrenal vein sampling is done by an interventional radiologist to put a little catheter up the groin, and then they go up and measure the aldosterone levels in the right adrenal and the left adrenal gland to see if there's much higher production from one side than the other, and if it is, that means that the tumor is located on that side. But remember, some of these tumors can just be a few millimeters, so they can be small, so that's why they don't always show up on the CT scan. And trust me that in many cases that we have had patients where the CT scan has been read as normal, we take a look at it and lo and behold, the tumor is there. It was just missed by the radiologist, because again, these are relatively small tumors, so unless the radiologist is very experienced, they may miss a small tumor on the CT scan. Yeah, so how do I know if I need adrenal vein sampling or not? I think I touched a little bit on that, but let's just spend a minute on adrenal vein sampling, because this is an important topic. And just to give some historical context, so when I was a chief of surgery, endocrine surgery at Yale and head of the endocrinology program at Yale, we discussed this, and at that time, so this is about 10 years ago, 10, 15 years ago, we and many other institutions in the US decided, let's do adrenal vein sampling on all patients. The reason for that was, number one, we weren't comfortable performing partial adrenalectomies, and we'll talk more about partial adrenalectomies and why that's so important to understand that concept. So if the only option for surgery is to remove the entire adrenal gland, then adrenal vein sampling becomes very important, because let's say you take out the wrong adrenal gland, well, then you're in between a rock and a hard place, right? Because the only option you have is to remove the entire adrenal gland. But that's not how we do surgery anymore. So, but that's how we used to do surgery. That's why adrenal vein sampling was very important. CT scans and MRIs weren't as good back in the day, so we couldn't trust them as much as we can trust them now. And frankly, we didn't see as many patients. We sort of had to keep the competency level up for the interventional radiologists because this can be a tricky procedure. So that's how we used to do. And probably when you talk to an endocrinologist or a nephrologist, 90 to 95% of those doctors still have trained in that mindset. So the new data we have nowadays, where we understand so much more about this disease and when adrenal vein sampling is needed and not needed, hasn't made it into the textbooks. It's not available, and people don't think about it. And since they only see 1 or 2 maybe of these patients a year, they rely on sort of textbook answers. And the textbook answer is still, let's do adrenal vein sampling on everybody. But the problem with that is adrenal vein sampling is an invasive procedure. It's not without risks. Thirdly, sometimes when we operate on these patients that have had the adrenal vein sampling, it's frequent that the adrenal gland or the adrenal vessel's been injured during the adrenal vein sampling. Even in the best of hands, it's only correct in about 70 to 80% of cases. And some studies from Germany shows that low volume interventional radiologists are only correct in doing this procedure in about 20% of the cases. So that means there's no free lunch, right? So nowadays, we reserve adrenal vein sampling for patients that really need it. So which are the ones that really need it? Well, the ones that really need it are those that have no tumor on the CT scan, and sometimes if they have tumors on both glands, unless the patient really wants both tumors removed anyway. And then for patients that really want adrenal vein sampling, that's reasonable to pursue adrenal vein sampling because every patient is different. Some patients will say, Dr. Carling, I really want to make 100% sure that that tumor that shows up on the scan is the one that's really producing aldosterone. And I don't mind having an interventional radiology study. I don't mind the risks of having the procedure, even though it takes some time. And I understand that it may only be successful in about 70 to 80% of cases. If that's the patient's view, that's perfectly fine, and it's reasonable to perform adrenal vein sampling. But it's also perfectly reasonable to forego the adrenal vein sampling for patients that have an obvious tumor on the scan where the other gland looks completely normal. So that's why so patients and other doctors ask me all the time, Dr. Carling, do you use adrenal vein sampling routinely or selectively? And I usually say I use adrenal vein sampling intelligently, and that's not to try to sound like to sound clever or anything like that, but we do use it intelligently, meaning we use adrenal vein sampling when we think it's going to benefit the patient, and I always have a discussion with the patient. And there's so many factors that factors in. It factors in exactly what the tumor looks like on the CT scan, the Hounsfield units, the characteristics on the CT scan, how old the patient is, how high the aldosterone levels are, how suppressed the renin levels are, whether they have hypokalemia or not, whether there's a man or a woman, what the creatinine levels are. All those things factor into my decision whether I would recommend adrenal vein sampling. And that's why being evaluated by a center where we see dozens of patients like this every single week, whereas even at most academic institutions, they might only see a handful patients a year. So that was a long answer to adrenal vein sampling. So just to summarize, in my practice, if the patient has an obvious tumor on the scan, it's reasonable to go ahead straight to surgery. But if the patient has no tumor on the scan, definitely would recommend adrenal vein sampling. And in some patients, and we'll talk about this, if the patient has tumors on both sides, it may make sense to do adrenal vein sampling as well. When I had adrenal vein sampling done, the procedure was aborted 3 times due to hypertension crisis. Is this a typical reaction during the procedure? No, this is not a typical reaction during procedure number 1, and it's not typical that you be subjected to having adrenal vein sampling 3 times and being aborted. This suggests to me that your blood pressure is not well maintained, and of course I would have to look at all the information, including whether you have an obvious tumor, whether you really need adrenal vein sampling in the first place, and why they have such difficulty controlling your blood pressure. But no, this is not typical, and to be honest with you, yeah, I would have to look at everything, but that is not normal, and I don't think anybody should be subjected to 3 adrenal vein sampling procedures that were all aborted. Can you have a tumor in another area causing Conn's syndrome, not the adrenal gland? No. So the only described diseases or the only described Conn syndrome, if you truly have primary hyperaldosteronism, it's either caused by a tumor or multiple tumors in one or both adrenal glands, or adrenal hyperplasia. There are some other rare diseases that can cause high blood pressure, and but if you truly have primary hyperaldosteronism, it's driven by the adrenal glands. It's not like Cushing's syndrome, meaning cortisol producing tumors, or hypercortisolism, which can be caused by ectopic tumors or a pituitary tumor or something like that. The only place in the body that produces aldosterone is in the adrenal glands. One thing that delayed my diagnosis was that my aldosterone and renin levels fluctuated a lot. Is that common? If so, why does that happen? Okay, that's a great question, and yes, that's very common. It's very common that the aldosterone and renin levels fluctuate. So let's start with the important point number 1. You have to measure the aldosterone and renin levels together, number 1. Important point number 2, in most patients, the aldosterone levels are normal, meaning in the normal range. Again, in most patients with Conn's syndrome, the aldosterone level is within the normal range. A lot of doctors don't know this, but and that's why it's so important to look at the aldosterone renin levels. So the aldosterone can sometimes be within the normal range and sometimes be above the normal range, and it can fluctuate in between there. The renin is actually a more important test. So the renin should always be on the low side. If the renin is not low, you just don't have primary hyperaldosteronism. But it can fluctuate a little bit, and I explain why. But that's why it's important to look at the aldosterone-renin ratio. The reason aldosterone and renin levels can fluctuate a little bit, and that's why it's important to look at trends. That's why I said you want to have your lab test done at least twice. But one of the main reasons that it can fluctuate is because of interference by medications. So blood pressure medications, as I mentioned in the beginning, can affect aldosterone, but it typically affect it in the sense that it lowers the aldosterone. So if your levels are borderline, that could be because of interference by the blood pressure medication. So removing or holding those blood pressure medications and then retesting you sometimes can help clarify the picture. But so that's one of the most common reasons that the blood pressure medications in of itself affect both the aldosterone and renin. But it's much more likely to err on the fact to say that you don't have primary hyperaldosteronism, whereas you really do. And sometimes your medical doctor may have to switch you to another blood pressure medication, especially if you're on spironolactone or Clarinon, to retest you. So you might have to come off that for as many weeks as 6 weeks, and then be retested again. So again, it's quite common that the aldosterone and renin levels can fluctuate, and that can be one of the frustrations and difficult thing for doctors to diagnose you. My left adrenal gland was removed in 2022. My blood pressure hasn't resolved, and I suspect the right gland is now having issues. Would you recommend the panel for me? Can I get the panel done outside of Tampa? Yes, so again, this panel by any lab test now is available at nationwide, so 230 locations nationwide. You can also have your regular doctor order it in a regular manner, but yes, I would definitely retest you for your aldosterone renin levels. So again, some patients will have multiple tumors on both sides, what we call multiple aldosterone producing nodules or micronodules. So number one, it would be important to look at what the pathology on the left gland showed first of all, because that gives us some clues of what's going on with your right adrenal gland. And then also what was your aldosterone and renin levels before surgery, and what are they now after surgery, and that would be able to we would be able to have a pretty good idea of what's going on with your right gland. So have the pathology evaluated, and then what your follow-up labs have been since 2022. Why is it that my radiologist has only done 5 adrenal vein sampling procedures in his entire career? How do I tell my doctor that I want a more experienced AVS doctor? Can I come to the Carling Adrenal Center just for my AVS? Yes. So Dr. Karan Patel, Dr. Patel, Patel, is the interventional radiologist that we partner with here in Tampa, and he performs more adrenal vein sampling procedures than anybody else in the country, and he is really good. So certainly that is an option. I can't tell you why your specific adrenal or an interventional radiologist do so few, but there's very few centers in the country that where they have significant experience. And why experience matters is that especially the right adrenal vein is very short, so if you have to be a little slick when you do these procedures, in the same way you have to be slick when you do adrenal surgery, so the interventional radiologist also have to be slick, because when they place that catheter, if that catheter is off by a few millimeters, you're sampling the blood through the IVC instead of the right adrenal vein, and that renders the whole study useless. So that's why experience really matters, and finding that right adrenal vein and sampling it perfectly is very important. So that's why it often benefits the patient to travel for adrenal vein sampling. So can Conn syndrome be cured? Yes, absolutely. In the vast majority of patients, the Conn syndrome can be cured. When we study patients and patient outcomes, we talk about 2 types of cures. We talk about biochemical cure and clinical cure. So with biochemical cure, that means that the aldosterone and renin levels normalizes, that the high potassium goes away. And clinical cure, that has to do with how much the patient's blood pressure gets better, meaning if the patient is on 2 blood pressure medication, do they come off all blood pressure medication? Or if they're on 5 blood pressure medication, do they come down to 2 or so? But in my mind, the most important definition of cure is the biochemical cure, because once you reduce that aldosterone level into a normal range, that significantly decrease all those risk factors. And there's certainly some patients where the aldosterone levels come down to completely normal, and the patient has some underlying regular hypertension, meaning essential hypertension, that's sort of underlying the Conn syndrome. And so the patient may still need to take 1 or 2 blood pressure medications, but that you still benefit a lot from the operation because your risk of cardiovascular disease and strokes and heart attacks and so forth is significantly reduced. Are there any natural treatment alternatives for Conn's syndrome? Yeah, the most natural treatment is to remove the tumor. Nothing could be more natural than that, right? You have a tumor and you remove it by surgery. But if you're talking about herbs or any other sort of treatments, none of those are effective. The only curative treatment is to remove the tumor by surgery, and that's certainly very natural. What is the mini-backscope adrenalectomy and why is it better? Yeah, so the mini-backscope adrenalectomy is the best adrenal operation for the vast majority of patients with adrenal tumor disease, and pretty much 100% of patients with Conn syndrome, because patients with Conn syndrome, they don't have tumors that are this big. The tumors are max up to a couple of inches or 4 centimeters or so, and most of them are just a centimeter in size. So the mini-backscope adrenalectomy is the best operation because it's done through the back, sort of the flank area, as opposed to go through the belly. And since the adrenal glands are in the back, it gives much more direct approach to the adrenal glands. So the operation is a lot faster. There's a lot less dissection of surrounding structures. It gives a lot better visualization of all the important vessels. So it's a safer operation. The cosmetic outcomes are better, and the recovery and the pain, less pain and faster recovery. So the traditional way is you do the operation through the belly. So just to get to the adrenal gland on the left side, you have to move the spleen, you have to move the colon, you have to move the bowel, you have to move the pancreas, move the left kidney, and on the right side you have to move the liver, dissect out the duodenum, the small bowel, the right colon, and so forth, just to get to the adrenal glands. And the more dissection you do, of course, the risks increases, because anytime you move and dissect organs, there's a risk of injury to those surrounding structures. So that's why the mini-backscope adrenalectomy is the best operation, and especially for Conn syndrome, and especially for partial adrenalectomy. It's very difficult to do partial adrenalectomy through the belly, just because of the fat padding that's surrounding the adrenal gland. You just don't see the structures the same way as you do with the mini-backscope adrenalectomy. I have tumors in both my adrenal glands. What should I do? Yeah, so this is a common problem. It's actually more common in patients with Cushing's syndrome, but also patients with Conn syndrome that can have bilateral tumors on both adrenal glands. And again, if the only option you have is to remove the entire adrenal gland, well, then this is a complicated thing, right? Because you don't want to remove both adrenal glands, because then you end up being on steroids for the rest of your life, meaning you have to take hydrocortisone, prednisone type of medications the rest of your life. The good news is that nowadays we do partial adrenalectomies all the time. So it's enough to have about a third of one adrenal gland. So you have 2 adrenal glands, you only need a third of one adrenal gland, and you don't need to take any steroids. So if you have tumors on both adrenal glands, often the best operation is to do partial adrenalectomy. So here the goals are twofold. Goal number 1, get rid of the tumors. Goal number 2, preserve enough adrenal tissue that you don't end up having to take steroids. And what you need to preserve is a third of one adrenal gland. So in many cases, when you have tumors on both adrenal glands, a partial adrenalectomy on each gland is the best option. Is it possible to have both Conn's and Cushing's syndrome at the same time? Yeah, great question. So we actually just went through our data of more than close to 1,500 adrenal operations, and of all those patients, so the most common patients we see are patients with adrenal Cushing syndrome, and the second most common is Conn syndrome. But of all comers that we do adrenal surgery on, 2% have both Conn's syndrome and Cushing syndrome. And that can manifest in a couple of different ways. Either, so you have two adrenal glands, so you have a Conn adenoma on one side and a Cushing adenoma on the other side, for instance, or you have one tumor that's overproducing both aldosterone and cortisol. So the combination of those two, and some clever person, not me, came up with this term Conn-shing, meaning Cushing and Conn combined, meaning you have both hyperaldosteronism and hypercortisolism. So again, 2% of all our patients. So we see that a few times every month where patients have both Conn syndrome and Cushing syndrome at the same time. So I had a pheochromocytoma on my right adrenal gland, which was removed. I now have hyperaldosteronism on my left gland. What can be done? Well, we actually not that long ago had a patient just like this. The patient had had a pheochromocytoma removed before and then developed an aldosterone-producing tumor on the other side. And it's quite straightforward. You do a partial adrenalectomy. Again, the key is what you want to preserve. So I want to preserve at least a third of the one gland that's normal. I presume that the entire right adrenal gland was removed when they removed the pheochromocytoma. But again, I see a lot of CT scans on patients that have had total adrenalectomies and adrenal tissue still left behind. So that's still a possibility. So I'll scrutinize the scan for that. But let's assume that the entire right adrenal gland was removed. Then we have plenty of adrenal tissue still on the left side, and presuming that the tumor is not that big on the left side, which aldosterone-producing tumors tend not to be, they'll definitely be able to preserve adrenal tissue on the left side. So again, partial adrenalectomy is the answer to that question. If you already have one adrenal gland removed and now you have a tumor on the other side, we do partial on that side, and that will fix the problem. I've been told my adrenal tumor is non-functioning, but I still feel terrible. Could it be a misdiagnosis? Yes, so certainly non-functional tumors do exist, meaning they don't produce any hormones. I would have to review all your lab testing, because we see this pretty much every day where patients been told they have a non-diagnosed or non-functioning adrenal tumor when in fact scrutinizing the lab testing suggests that they either have and it's typically either hypercortisolism or hyperaldosteronism. So I would have to look at all those lab testing. Of course, there's other diseases in the world that can make you feel terrible, but I would have to scrutinize those labs, because we certainly see that every single week where patients been told that the adrenal is not the problem when it really is. Will I still need blood pressure medications after surgery? So again, it depends. So the results when you operate on patients with Conn syndrome is that pretty much all patients, if they have low potassium, that normalizes. The blood pressure pretty much gets better in 100%, and patients feel better. Then the question is, for the patients where the blood pressure gets better, how much better does it get? Well, so typically, so it depends on a few factors. Number one, the ones that tend to do best in terms of the blood pressure normalizes tend to be patients that are younger, that have had Conn syndrome shorter period of time, that has completely normal kidney function, that are younger and tend to be female. Those are the ones that tend to be the ones that come off all blood pressure medication. They're done, no more blood pressure medications, no nothing. The patients that are more that going to see an improvement in the blood pressure and benefit from the surgery, but may still need some underlying blood pressure medication after surgery, tends to be the ones that have some kidney damage, that are older, that have had high blood pressure longer, preferentially men, and patients that also have other risk factors such as obesity or history of smoking and so forth. Those are again will improve their blood pressure, but say for instance they are on 5 blood pressure medication, a realistic goal would be to get them down to 2 or 3 blood pressure medications afterwards. But again, it's not only about getting the blood pressure better, reducing the aldosterone levels in of itself prevents strokes, heart attacks, further kidney damage and so forth. So even though the blood pressure doesn't completely normalized, doesn't mean that you don't benefit from the operation. You still benefit tremendously from the operation. It's just a question that you have some underlying essential hypertension. And again, the longer you wait to be treated, the less effective the surgery is. So the better. So the sooner we detect patients, the better. And that's obviously one reason why empowering patients to have their lab testing done is very beneficial with any lab test now. I have an adrenal tumor on my left adrenal gland. I have extremely high aldosterone and very low renin. I'm in Canada and my endocrinologist is on the fence about whether the tumor should be removed. Should I push to have surgery? Absolutely, 100%. So if you go on my website, adrenal.com, you would be somebody we would call an aldo slam dunk, meaning it's so obvious that you have hyperaldosteronism, and just what you're describing here, you're sort of the stereotypical patient that would do extremely well from surgery. So again, the higher the aldosterone levels are, if the renin is completely suppressed, which sounds like you have, and you have an obvious tumor on the scan, those are 3 very important prognostic indicators that you would do supremely well with surgery. So frankly, I'm not sure why your endocrinologist in Canada is on the fence. It may be because they don't have access to a high volume surgeon. So we do get a lot of patients from Canada that fly down for surgery. But if I were you, I would bend over backwards to get this done. How accurate are CT scans in detecting aldosterone-producing tumors, and can small tumors be missed entirely? Yes, so overall CT scans are quite accurate. So there's 2 factors when it comes to CT scan, right? So it's the actual scan, whether that's done correctly, and the correct way to do a CT scan is what's called an adrenal protocol CT scan. But then the other factor is the radiologist that interprets the CT scan. So you need to have a good scan and a good radiologist to interpret it. That's point number 1. But when that's the case, it's quite accurate. But still, for small tumors that we've discussed, there's can be missed by the scan, and that's often where adrenal vein sampling should be performed. So if there's no obvious tumor on your scan, that's when the adrenal vein sampling should be performed. I should mention that there's some research that's being done throughout the world when it comes to functional imaging. It's not readily available in the United States, but it's a PET-based technology. You might have heard about PET scans when it comes to cancer care, but PET scans, if you use a very special radio tracer, can show some promise in the research setting in picking up small tumors that could have been missed by a CT scan. So there's certainly active research going on through the world to improve the imaging. But for now, we rely on CT scans for the most part. In most cases, they're accurate, but if they're negative, having adrenal vein sampling would be beneficial. Will I ever feel normal again after treatment? I've forgotten what that feels like. Yeah, so when it comes to feeling normal, I think the best people describing this are patients that have experienced this themselves. So if you go on consawareness.org, there's a number of previous patients of ours that sort of tell their story. And I think it's most, of course I talk to patients every single day and they tell me how they feel, but sometimes it's even more powerful to hear from other patients that gone through this themselves. So go to consawareness.org and listen to some of their video testimonials where they explain how they feel. And I would say the vast majority of patients see significant improvement in their energy level, and their sort of the mental fogginess goes away, and of course the blood pressure and the palpitations and muscle cramping and all the different symptoms that you all know about. If I have these panels completed at any lab test now and they come back as indicative for Conn's syndrome, what's the next step? Yeah, great question. So the next step is to print it out, bring it to your doctor. As I mentioned, it's always good to repeat aldosterone renin at least twice. But if you really have the disease after you had that measured twice, the next step would be to do an adrenal protocol CT scan to look if you have tumors in the adrenal glands. I love this initiative with any lab test now. I wish you had this for Cushing syndrome, as I suspect that over Conn syndrome. Yeah, so we got some great news for you when it comes to that. So as a first sort of initiative we're doing was to focus on Conn's syndrome and testing for Conn's syndrome with aldosterone and renin. But we are partnering again with anylabtestnow.com and now during the Adrenal Awareness Month. So you'll hear more about our efforts both when it comes to screening for Cushing's syndrome and pheochromocytomas. So please make sure you follow us on Facebook, on Instagram and YouTube. There'll be more videos about this, but there'll be panels both for testing for Cushing's syndrome, which includes cortisol testing, DHEAS, ACTH levels, as well as for pheochromocytoma with plasma and urine metanephrine, adrenaline type hormones that we would check for. So with that, we're going to conclude this Q&A session. It's been great, and thank you all so much for sending in great questions. Please continue to follow us on social media. Tell your doctors and your loved ones and other ones about hyperaldosteronism, why it's so important to be screened if you have high blood pressure or low potassium, but all patients with high blood pressure really should be screened for this disease. Share the link to adrenal.com as well as consawareness.org. So thank you so much, and you guys have a great evening.